rather nice example of a neutral trial, but in the subset with LV dysfunction, although there may be a higher procedural risk, there was a greater benefit overall over time. Now, this same thing happened in the ischemia trial. Now, the more recent ischemia trial of PCI was a neutral trial. But if you look at the 8% of patients in this trial who had either a history of heart failure or LV dysfunction, in these 398 patients, what you see now in this neutral trial is a clear benefit in orange for the invasive arm in those patients with heart failure or LV dysfunction. And in the conservative arm, this is the dotted line. This is the composite endpoint that was used in that trial. But again, an example that patients with LV dysfunction are at higher risk, but the potential for long-term benefit is substantially increased. In other words, the greater the risk, the greater the long-term benefit. If you look at those patients in this trial who did not have heart failure or LV dysfunction, you now see in the solid lines that there was no difference between PCI or medical therapy, and it is a statistically significant interaction. So it really raises a lot of questions about what are the mechanisms of benefit of revascularization in patients with LV dysfunction, or the lack thereof in most of the trials which have actually been neutral, and those are mainly patients with normal LV function. Now, if you look at the ischemia trial, this is all-cause mortality and myocardial infarction in patients with severe ischemia, conservative in yellow, invasive in orange. And what you see that in patients with severe ischemia, as opposed to mild ischemia, there really was no benefit at all from the invasive approach versus the conservative approach. But if you look at the Duke score of the anatomic severity of disease, whether it be 3-vessel or 2-vessel plus proximal LAD, what you now see in those with severe disease, a reduction in late myocardial infarction in the invasive arm that is not present in the conservative arm. And at the 4-year rate of cardiovascular death and MI was lower in the invasive strategy, the difference being statistically substantially significant. So why was ischemia not a marker, or the severity of ischemia, why did it not have an impact on late outcomes? And this is one of the big unresolved questions from the ischemia trial. First of all, I suppose ischemia is one of many factors that may impact on prognosis. There could be a selection bias in regard to trial enrollment. Another factor is 88.1% of patients in this trial had moderate or severe ischemia, so there were not enough patients with mild ischemia to really do a statistical comparison. So it may just be a matter of statistics. They used 4 different imaging modalities to quantify ischemia, which would dilute the impact. And perhaps the other explanation, which I'll come back to right at the end of this talk, is the presence of ischemia is a marker of a greater atherosclerotic burden. And the majority of these plaques are non-obstructive but vulnerable. And we really don't know at all what the impact of revascularization will be on these non-obstructive plaques versus medical therapy. And this is an unresolved question. Now, in regard to LV dysfunction, there's been one trial specifically confined to patients with an ejection fraction of less than 35% and coronary disease. And this was the STITCH trial, which initially was a neutral trial. Although you can't see it on this slide, there was a slightly higher hazard ratio with bypass surgery early on. And at 3 years, when the trial was first presented, there was no difference between the two groups. But we all felt that it would be a matter of time and they needed longer-term follow-up. And what you see is that the curves cross over, and by 10 years, there was a statistically significant difference with a hazard ratio reduction of 16% in favor of bypass surgery. The same thing for death from cardiovascular causes, and the same from death from any cause or cardiovascular complications. Showing again that there is a higher risk to begin with, but ultimately a quite impressive benefit from bypass surgery on the primary outcomes, number needed to treat only 14. What are the mechanisms of improved prognosis following revascularization in patients with LV dysfunction? Well, what we'd like to think, or the standard accepted prevailing theory, was that you get recovery and hibernating myocardium with an improvement in resting ejection fraction as hibernating myocardium gets revascularized. But in fact, there may be many other mechanisms. One is that in these patients, there is a reduction in inducible ischemia and repetitive stunning, which in turn may improve diastolic dysfunction and symptoms of heart failure. Furthermore, hibernation, which is characterized by ischemia, by reducing inducible ischemia and repetitive stunning, you may also get a reduction in ventricular remodeling, and that in turn may reduce the symptoms of heart failure. Another explanation, which I really believe in, and that is that acute ischemia is very arrhythmogenic, and that one other mechanism of benefit in the STITCH trial was prevention of ventricular arrhythmias and sudden cardiac death. And finally, I think there is now increasing evidence that the benefits of revascularization in patients with LV dysfunction are independent, actually, of the prevailing theory that you will get an improvement in ejection fraction. But maybe what happens is protection of residual viable myocardium, which is so-called hibernating myocardium. But by providing blood flow to that area, you reduce subsequent acute coronary events, irrespective of any change in ejection fraction. What about myocardial viability and survival? This was a great surprise in this trial. This was not the trial, this was the viability sub-study. If you look at patients with viability, there was a 14% reduction in mortality with bypass surgery. In those without viability, it was actually a 30% reduction. Neither of these were statistically significant, but what was really surprising was no effect of viability on the outcomes following surgery. And in fact, the patients without viability seemed to have a slightly better effect from surgery. But this is still controversial and still being debated in terms of the actual mechanisms. It could be that the idea just might be another beautiful hypothesis slain by ugly facts. But my own feeling about viability is that it is a valid and rational concept. It didn't apply in the STITCH patients. And this is a very sick group of patients. And there seemed to be no effect of viability, ischemia, and angina on surgical outcomes. And although patients with viability had less remodeling, it had no effect on surgical outcomes. But that doesn't mean that what we saw in this sick population in STITCH does not apply to other patient subgroups. And what I think is absolutely key in regard to the role of revascularization in patients with severe left ventricular dysfunction is not just the presence of viability or ischemia, but this should be taken in conjunction with the extent of scar and remodeling. And we use MRI and PET, and this is the most valuable technique if available. But I don't believe you can just look at viability ischemia and disregard the extent of scar formation and the extent of remodeling. So what about the REVIVE trial presented at ESC and published in the New England Journal a month ago? 700 patients, ejection fraction less than 35%, an extensive what's called a jeopardy score, developed by the British Cardiac Interventional Society. They had viability testing using a variety of current techniques. Viability had to be present in at least 4 segments. that could be revascularized by PCI, and they were randomized to medical therapy alone versus PCI and medical therapy. A well-designed trial. And the results came as a stunning surprise, I think, to everyone. In terms of all-cause death and hospitalization for heart failure, absolutely no impact whatsoever from PCI as opposed to the Stitch trial using bypass surgery. And this came as a huge surprise and is still, I think, under investigation in terms of future sub-studies from the Revive trial. What are some of the potential implications or explanations for the discordance between Stitch and Revive? Well, Revive is a 15-year-old trial, and we now have new changes in optimal medical therapy, antithrombotic agents, SGLT2 inhibitors, SGLP antagonists, and cubital cell valsartan. That maybe account for some of the difference, but personally, I think the complete lack of difference in Revive compared to Stitch remains, I don't believe, can be accounted for purely on the basis of changes in medical therapy. ICD use greater in Revived, CRT use greater in Revived, and that may be a factor explaining some of the lack of difference. This, to my mind, is really important, and that is, I know that patients in Revived had myocardial jeopardy because of the jeopardy score and the anatomic distribution of disease, but how much ischemia did they have? And if you look at the ejection fraction in both trials, it's the same. What surprises me is an ejection fraction of 27% in Revived, yet the majority of patients had double vessel disease. Could this mean, does this mean that coronary disease is responsible for the low ejection fraction, or could there be coexisting diseases? It seems to me a very marked drop in ejection fraction for relatively limited disease in terms of 58% with double vessel disease. And then how much ischemia, again, versus jeopardy? 2/3 of patients in Revived had no angina. 31% had class 1 to 2. So 2% had severe angina. And this is something that needs to be investigated and studied further. Possible selection bias. It's certainly possible that those patients with more extensive coronary disease, namely triple vessel disease, in Revived were not in Revived, and they were referred for bypass surgery as opposed to PCI. And that could be a factor. And then the other, I think, key factor is the whole issue of targets. With PCI, you address the culprit or culprit lesions. With bypass surgery, you don't just look at culprits, you also look at future culprits down the rest of the vessel. And I'll show you an example of that in the next slide. There's a greater potential for bypass to prevent future acute ischemic events by restoring flow in dysfunctioning regions supplied by fatal chronic occluded vessels. And bypass-induced protection from subsequent acute events at the site of vulnerable future plaques may play a role in accounting for the difference between bypass and PCI in these two trials. And this is what I mean by the previous slide in terms of culprits and future culprits. PCI addresses a culprit lesion or lesions. Bypass addresses the entire epicardial vessel, which is not just the culprit lesion, but future culprits, namely these vulnerable non-obstructive plaques that may be the cause of coronary events in the future. It may protect hibernating myocardium from subsequent ischemic events by providing flow distal to occlusions, to total occlusions, and that may be another benefit from bypass. And then there's a lot we don't know about the role of microvascular dysfunction. Well, this has been reported previously, but not in a trial. This is from the Swedish Angioplasty and Angiography Registry, and a subset of 2,500 patients, 73% of whom had an ejection fraction less than 30%. And if you look at PCI in yellow and bypass in orange, all-cause mortality significantly improved with bypass surgery. And the odds ratio is quite striking. In terms of all-cause mortality, the odds ratio is 0.62. That is a 38%, a 62%, an odds ratio of 0.62 in favor of bypass surgery over PCI, a substantial and significant difference. So what do I think we've learned from this? Stitch demonstrated the proof of concept, but the mechanisms of benefit of bypass surgery in patients with severe ischemic cardiomyopathy are multifactorial. The surprising results of the REVIVE trial suggest that the role of PCI in patients with severe LV dysfunction would be to improve anginal symptoms in patients who are not good surgical candidates. And I don't think that with the current data, if a patient with severe LV dysfunction is a surgical candidate, they should not be referred preferentially to PCI. But if they're not a surgical candidate and they have significant life limiting the quality, angina limiting quality of life, and they're not good surgical candidates, then I think PCI is a reasonable indication. A head-to-head trial comparing the two is under consideration by the so-called Stitch 3 consortium. So I want to close with two slides. This is a slide that looks at coronary flow reserve. And coronary flow reserve with PET is a measurement both of epicardial obstruction and microvascular function. It's total blood flow. And you see that in this study from the Brigham and Women's Hospital, Dr. Tuketi, it's only 329 patients. But if coronary flow reserve is high, implying a functioning microvasculature, the difference between medical therapy, PCI, and bypass surgery was not significant. But if coronary flow reserve was low, due to an anatomic obstruction and or microvascular dysfunction, now you see a very high mortality with no revascularization, and bypass surgery is indeed better than PCI, although PCI looks to be superior to medical therapy alone. And I think this really points to the future, and that is perhaps we're moving into not just the era of anatomic plaque severity, but plaque characterization and the vulnerability of plaques as new targets for therapy. And this is a review just published in the last month. And I think all the data points to something that Drs. Kasky, Filippo, Crea have been writing about substantially for years, and that is the role of the microvasculature. And so I think we've learned a lot from these trials. There's still a great deal more that we need to learn and needs to be studied. But I do think we are moving into a new era as we start to understand why it is that revascularization benefits some patients with severe LV dysfunction. Thank you very much for your time.
Thank you, Professor Gersh. Unfortunately, we are running late and there will be no questions, but very interesting talk. Thank you. And now we are going to close this session, this joint session with the Moroccan Society of Cardiology, PAFSIC, and the European Heart Journal. Thank you for everyone, but keep seated. We are closing the session, but we are going to just opening the Congress with our president.
بسم الله الرحمن الرحيم. السيد رئيس الدورة الإفريقية لأمراض القلب التداخلية، السادة رؤساء الجمعيات أمراض القلب، السادة المحاضرون القادمون من مختلف جهات العالم، عزيزاتي الزميلات، أعزائي الزملاء، سيداتي سادتي، في البداية إنه لشرف عظيم لنا أن يكون هذا الملتقى تحت الرعاية المولوية السامية لصاحب الجلالة الملك محمد السادس حفظه الله ونصره. وبهذه المناسبة تتشرف الجمعية المغربية لأمراض القلب بمكتبها المسير وجميع أعضائها أن ترفع للمقام العالي بالله أسمى عبارات الولاء والإخلاص والشكر والامتنان. إن هذا التشريف يلزمنا بمواصلة العمل لضمان تكوين طبي مستمر يليق بمغربنا العزيز، ويحثنا في نفس الوقت على الاهتمام بالتكوينات الأساسية المتعلقة ببعض التخصصات الفرعية كمراقبة إيقاعات دقات القلب، وذلك بموازاة مع البرامج التكوينية المعتمدة في كلياتنا المغربية. إنها المرة الأولى التي تنضم فيها الجمعية المغربية لأمراض القلب مؤتمرها السنوي بمدينة طنجة، التي تنظم فيها الجمعية المغربية لأمراض القلب مؤتمرها السنوي بمدينة طنجة، وهو مؤتمرها 27. يتزامن هذه السنة مؤتمر جمعيتنا مع تنظيم المؤتمر 23 للدورة الإفريقية حول تقنيات قسطرة القلب. ذلك ما سيمكننا من الانفتاح على إفريقيا. وبالمناسبة أغتنم هذه الفرصة لأقدم شكري الخالص للبروفيسور حبيب قمرة الذي اقترح علينا هذه التوأمة بين جمعياتنا. بعد خفة وطأة وباء كوفيد أتمنى أن تتعزز هذه الشراكة جنوب جنوب وتتعدد وتستمر اللقاءات في المستقبل لنتدارس مشاكلنا على أرض الواقع، على أرض إفريقيا. تعتبر مدينة طنجة جوهرة شمال المغرب، فهي تتميز بتاريخ عريق متجدر وموقع جغرافي فريد بين البحر الأبيض المتوسط والمحيط الأطلسي، يسمح لها بالانفتاح على العالم، مما جعلنا نستلهم من خصوصياتها هاته وننفتح بدورنا على جميع أطباء القلب على المستوى الدولي. ستكون ابتداء من هذه السنة اللغة الرسمية لمؤتمرنا اللغة الإنجليزية، والتي يتعين علينا التشبث بها للحفاظ على التجدد والانفتاح الواسع على البحث العلمي، علما أن ذلك لن يمنعنا من تنظيم اجتماعات تحت إشراف جمعيتنا إما باللغة الفرنسية أو إما باللغة العربية. يتضمن برنامجنا العلمي محاضرات حول مواضيع مختلفة ذات راهنية وتداخلات تتركز على التوصيات الجديدة للجمعية المغربية لأمراض القلب وللجمعية الأوروبية لأمراض القلب، وكذا دروس وإيقاعات دقات القلب بالنسبة للطلبة المقيمين والماستر الخاص بأمراض القلب والأورام. ولا تفوتني هذه الفرصة دون أن أتقدم بأحر تشكراتي لكل فاعلين الذين ما فتأوا يقدموا لنا الدعم الدائم واللا مشروط، مختبرات الأدوية وشركات الأجهزة الطبية، والذين لولا دعمهم لما تمكنا من تنظيم هذه التظاهرة. أشكر جميع أطباء القلب على دعمهم للتغيير الذي أحدثناه، وأنحني تقديرا للعمل الهائل الذي قام به أعضاء مكتب الجمعية المغربية لأمراض القلب لتزويدنا ببرنامج غني ومتنوع وعلى انخراطهم التطوعي الكبير. تقدير خاص لأطباء أمراض القلب الذين حضروا من البلدان العربية الشقيقة ومن فرنسا، والذين قدموا لنا المساعدة كما جرت العادة بذلك لإنجاح هذه الدورة التكوينية المستمرة. وكما أشكر زملائنا الجدد الذين حضروا من بلجيكا وهنغاريا وصربيا والأرجنتين وكندا ورومانيا، الذين استجابوا لدعوتنا بصدر رحب وحماس كبير. الشكر الجزير للسلطات المحلية بطنجة على حفاوة الاستقبال. ننتهز هذه الفرصة لنستحضر أرواح زملائنا الخمسة الذين غادرونا إلى دار البقاء، نطلب لهم المغفرة والرحمة. وختاما نسأل المولى عز وجل أن يحفظ ملكنا الهمام ويسدد خطاه ويشد أزره بولي عهده الجليل وبباقي الأسرة الملكية العلوية الشريفة، وأن يحفظ بلدنا العزيز المملكة المغربية، وأن يحفظ الوطن العربي والوطن الإسلامي، ويحمي السلام في جميع أنحاء العالم. وشكرا لكم والحمد لله رب العالمين.
Shukran, Sir Hamid. And thank you very much for the speech and for once again for accepting to host PEPSIC to be organized jointly with the annual meeting of the Moroccan Society of Cardiology. It's a privilege and an honor to be here with you. I think we have saved the best for the last, and it's the time now to introduce someone that you know, all of you, Professor Alain Krivier. I have a special relationship with him because he's my mentor, he's my friend, he's my big brother, and he affected considerably my career in many ways, in ensuring my education in Rwanda and in the United States. And then after that, and he have been a great support of this particular meeting for the 23rd edition. I think he did not miss any of those, or maybe one or two. So maybe two. Muhammad Safi knows the numbers. So it's my privilege now to introduce Alain Krivier. He will be giving us a keynote lecture on the topic that he's very well known about. Alain Krivier, he has been the star of interventional cardiology, not this year, but for many, many years, since 1985, when he has invented the aortic valvuloplasty, and later on. Now we're celebrating his presence with us just because it's the 20th anniversary It's the 20th anniversary of the first TAVI, and Alain will be giving us a lecture entitled Lessons from 20 Years of TAVI, Implications for the Introduction of TAVI in Africa. Alain, welcome.
Habib, thank you very much for this introduction. And I don't know if I should speak English or French, because the president of the American Society of Cardiology said that I could speak French, but I don't know, what should I do? What do you want? Wish for French. Ouais, ok, bah, je peux peut-être parler français. My slides are in English, so if you don't mind.
You would not be happy.
Okay, okay.
So,
Habib, you won't be angry against me?
English, everybody will understand.
What do you want, Habib?
I think English is...
English, well, okay, fine. So first of all, it's an immense pleasure for me to be here again with you in Tunisia. You know that I am very attached to this country and to the people working there. not only Abby, but all the friends from Tunisia and Morocco. And it's a privilege for me to be here at almost every meeting and to meet you again. So I have been very kindly asked by the Society of Morocco to speak about the lessons that I have been learning myself after 20 years of TAVI and the implications for the introduction of TAVI in Africa. Okay, first of all, I just would like to remind you that on May of this year, we had a very moving celebration of the 20th anniversary of TAVI. It was in Rouen. We had more than 500 participants coming from every country. And it was very, very, very moving for me. You know, it proved the interest of the international cardiologists for this not so new technology that we call TAVI. So TAVI, 20 years later, where are we? There is an amazing expansion worldwide of this technology. You know, with today more than 2 million procedures performed in more than 80 countries in the world. And we are expecting a growth of 40% per year. I'm sorry, I have some problem with the slideshow here. Okay, well, I'll lose the first slide, but well, innovation, you know, because we are supposed to speak about the lessons. You know, the innovation is a very difficult task for the interventional cardiologists that might take an essential place in your life, thinking of it day and night. So you have to make sure that your idea does really correspond to an essential clinical need and presumptuously believe that you are able to solve it. So this was the case in '85. I was coming back from United States. I had the chance of working with Professor Swan and Gans, great innovators. And I was able to detect a major unmet clinical need. 50% of our patients in France and everywhere else in the world, elderly patients with symptomatic AS, aortic stenosis, were turned down at that period in the 80s for surgery, the only possible life-saving treatment, and they all died within 2 to 3 years. So I did consider that kind of unacceptable. You know, I was having patients coming back. They had been turned down by the surgeon. They were coming back to the department and in heart failure, and they were dying very, very, very often. So the first technique that I tried to promote was dilating the valve with a balloon. That we call balloon aortic valvuloplasty, and which was considered a silly solution by the surgeons. And we tested it for these patients, and it worked out very well. I'm sorry, because I don't know why the next sentence is... Our first series were published in The Lancet, and was followed by uncontrollable worldwide expansion. Over this time, there was always a fierce opposition of the surgeons that did consider balloon aortic valvuloplasty as unrealistic and impossible to dilate the calcified valve. And they were very happy to see that non-lasting results of balloon aortic valvuloplasty were definitely confirmed after a huge US registry. And what to do next, giving up or finding a solution? You know, it's classical to say that balloon aortic valvuloplasty was a failure. Actually, I am happy to see that, first of all, it had been approved by the FDA in selected patients, but also that we are using the same technology today on everyday basis while doing TAVI to predilate the valve or to overexpand the valve, so it's still working. I have some problem with that, yeah. I'm sorry, I have a problem with the It doesn't work. Would you have another one? Or... Est-ce que tu peux demander à Habib si on peut avoir une autre? Ah, ok. So I am going back on the very first slide. You know, it was to explain to you how it is difficult to innovate in medicine. And when you want to innovate, you have to be ready to face a number of obstacles. There is misunderstanding, doubt, skepticism, criticisms. If this could be done, it would already exist. You will kill the patients and you are crazy. This was a common observation around me. So my advice for those who want to innovate in medicine today is that remain stoic, do your best to demonstrate the feasibility of your concept, never be discouraged, never give up. One key word, perseverance. And you know, also, and it has been my case with the development of TAVI, the chance may be on your side. I have still problems to go to the next slide. It doesn't work, you know, I'm sorry for that, but if you don't have any other system, but I cannot go on the next one. It's blocked. Would you have any solution?
Est-ce qu'on peut faire avancer les diapositives?
Okay, ça va.
Une par une.
So in 90, was the birth of the idea of TAVI as a solution against early restenosis post-BAV. I had to find another solution. So I developed the most challenging, crazy concept. Implanting a valve prosthesis within the diseased calcific native valve, it means without removing it, on the beating heart, using regular percutaneous catheter-based technique and local anesthesia. I said local anesthesia because general anesthesia was very often one of the good reasons for having a patient stir down for surgery. And when I was talking of this idea around me, it was in the 90s, it was always considered impossible and dangerous. And I can understand the surgeons, you know, they were facing every day this kind of lesions, you know, and so they all said that it was impossible and dangerous. Which is impossible is to go to the next slide. Next slide, please. So impossible because of these heavily calcified valves, and they said, I am sorry, but I am afraid that my talk will last 2 hours, that there was no chance of crossing the disease valve with the prosthesis and deployed it. And also, it was considered very dangerous by surgeons because of the surrounding structures, just above the valve, the coronary ostia, and just below the valve, the mitral valve, and the His bundle. Actually, I had to validate the concept of valvular stenting, and validation is a big part of the research program. So I had the regular observations during balloon aortic valvuloplasty that we can always observe that the balloon can be circularly open, fully open, in all cases, whatever the amount of calcium. So came the idea that I might implant a stent at the same time, and to maintain the valve open. So we had to find a good stent, and we had to think about placing a valvular structure in it. So there was a good question, could a balloon expandable stent be used to maintain the valve open? So we did a major landmark autopsy study in Rouen with my colleague Alain Krivier and my other colleague René Koning. It was really a landmark autopsy study because it was the beginning of everything. I could observe that when we implant a Palmas stent, it was a peripheral stent recently launched, 23 millimeter in diameter, within the native valve, we can always open the stent circular. So when I show these slides, you know, people say, well, this is not a major aortic stenosis, you know, not so much of calcification. But you see that Renu Virmani in Washington had the same confirmative observation on very, very calcific valve. And you see that even in this terrible case above in the middle, the stent can be opened totally, circularly, pushing aside all the calcification. So this made possible the idea of using a stent to open the valve, and we just had to find a valvular structure to be placed in it. Also, in our study, we used to cut the aorta vertical, and as you can see on this slide, I could demonstrate that the 17 millimeter height stent was not occluding the coronary ostia, and in any patients, was not impacting the intraventricular septum with the His bundle, and was not injuring the mitral valve insertion. So this slide was for me magic, because with this picture, I could go and try to find somebody to help me to develop this technology. Unfortunately, during 5 years, between 94 and 99, I contacted every biomedical companies in Europe, in United States, in India, in Brazil, in Russia. And the comment from all the experts, who were all surgeons, of course, because we are talking about aortic stenosis, said that it was strictly unrealistic, major technical issues, definitely impossible to stent a calcific valve, unavoidable life-threatening complication that you can see here listed, would never be approved by the FDA, and that surgery covered 100% of the need, which was not true, and there was no indications to develop this technology. It was the most stupid project ever heard. Just forget it. This was something that I heard several times. So it could have been the end of the story, and I must say that after 5 years, I was a little tired, of trying to find a sponsor, but persistent won out. Luck. Luck is an important factor. In spite of all this opposition, the project goes on. I was very lucky to meet 2 engineers from Johnson & Johnson in a meeting in Paris, Stan Rabinovich and Stan Rowe, and they unbelievably were very receptive to this idea. They spoke with Martin Leon, who was at that time the great cardiologist, US cardiologist. He was at that time the clinical medical director of Johnson & Johnson. And we created a partnership, and we built a startup that we call percutaneous valve technology to make this project happen. So you can see here the 4 of us, at the time of the creation of percutaneous valve technology. And we were lucky enough to find a small partner in Israel, the Aran R&D, that you can see here on the screen. This very small company was very aimed at developing medical treatment, and they accepted to be our partner and our first sponsor. With this company, and starting with the drawings that I made for obtaining a European patent on the valve, they made this unbelievable device, a device made of a stainless steel stent containing a tricuspid valve, which was made first in polymer, then in horse pericardium, with a single diameter of 23 millimeter. And this valve, when compressed over a balloon, it needed a sheath size of 24 French, which means more or less 8 millimeter. That made compatible the performance of this procedure through the femoral artery. But Martin Leon, who was my partner in this startup, said try to sell the technique to Aran, and when he was contacting them, he said 15% chance of success in creating an impossible technique for patients who have 1 foot in the grave and the other one on a banana peel. So he was not very optimistic. Actually, this valve was submitted to a huge preclinical evaluation. We had a number of laboratory tests during 2 years. And I don't show you all the tests, but you have here the valve, showing the durability over 5 years. And we started with Hélène Elchaninov in Paris, a very important in vivo experiment on the sheep model. We implanted more than 100 sheep with valve. And we were working in excellent condition at the Hospital Montsouris in Paris. And with that, we were able to implant the valve in the aortic position, as you can see in the middle. And we also developed a protocol to implant the valve and keep it working 5 months in the intra-aortic position. And you can see how good the valve was working. This was important for the further FDA approval. Moving from dream to reality, and we did this first-in-man case in April 16, 2002. We received a man, 57 years of age, dying with severe aortic stenosis, with a bicuspid valve, type 1. Ejection fraction was down to 12%. He had a lot of comorbidities, including pulmonary cancer. He had an intraventricular floating thrombus. He had no femoral access because the bypass were recently occluded. He had an acute leg ischemia, and he will die of that 4 months later after leg amputation. And we had to use for this man the transeptal approach, which was not easy to think about, you know. And we did this procedure under local anesthesia without a transthoracic echo, transesophageal echo. Well, actually, we had to follow the arrows. You know, the valve was coming from the femoral vein. We were crossing the septum. We were turning around the floating thrombus in the left ventricle to reach the valve. And on the right, you can see the catheter following this way with the valve placed in the middle of the calcium. And we were very lucky that this procedure can work out very well. So I did that with my friend, who is now chief of the Department of Cardiology in Rouen, Hélène Elchaninov, and another colleague who is still working there, Christophe Tron. And you can see here, you know, the atmosphere in the cath lab at the time of valve positioning. For example, it was extremely stressful. The valve could be finally opened just in the middle of the calcium deposits. You can see Hélène, you know, at the time of valve delivery. This was the first time that the valve was delivered by inflation of a balloon in the world, and it was made by a woman, so I am very proud of that. And this is a valve implanted in the right position. This is a result immediately. It was a magic result, you know, with a raise of the aortic pressure to 100. I could interrupt the treatment by vasopressors at that moment. There was no more gradient. And I am sorry for this in French, but there was an immediate and spectacular clinical improvement. And you can see here the echo data that we had on the cardiac table. Gradient decreased to 10 millimeter of mercury. The valve area increased to 1.7 square centimeter, and the normal functional left ventricular function. So this case was a real miracle, and it was published in Circulation with a very great effect on everyone in the world. So the lessons: fighting with the experts of the health authority in France, whose wish was clearly to kill the technique. Because the experts said, okay, you can make a first series. It took 1 year to get this clearance. But you have to do that on dying patients with a life expectancy of less than 15 days. And you have to use a transeptal approach because this is the approach that we used in the first patient. So it was really, really challenging. And in spite of that, we know we could include 38 patients with a procedural success of 85%, an incredible improvement of patients up to 7 years with absolutely no symptoms. And I show you again this lady, you know, who was the number 3 in this series, who were dying in Paris. She was at home. She had been hospitalized more than 1 month in Pitié-Salpêtrière, a big hospital in Paris, and the physician said to the family, you should take her back home because she will die. And she was watching the TV and saw the report on the first patient, and she said to her daughter, send me to Rouen, this man will save my life. Actually, I did not believe myself that it would be possible. But 1 year later, she was able to travel to Washington, at the TCT meeting. You know, this was absolutely unbelievable, and the improvement of the patients had a major impact on the dispatching of the technology in the world. TAVI took its flight in the world. You can see here the first people who did a TAVI procedure in the United States and in Europe. And in 2005, we had an experience of 100 TAVI performed. In 2004, Edwards Life Sciences, one of the companies who refused to help me at the beginning, acquired percutaneous valve technology, and our vision became true. You can see here the slight modification that it made on the valve to create the Edwards Sapien valve with an additional 26 millimeter of diameter. It was a Carpentier-Edwards valve inserted inside a stent, and they developed some delivery system that allowed to do the transfemoral approach very easily. And they also, 1 year later, developed the transapical approach. And with these two approaches, we were able to treat all the patients requiring TAVI. So there were multiple feasibility trials in high-risk patients, a major trial called Source Registry, and this led to a fast expansion of TAVI in Europe. At this stage, no one could have predicted the incredible success and fast expansion of TAVI in the world. The reason of success: improved device technology and skill. Of course, there was a growing experience of the teams. There was a better patient screening, and this was absolutely fundamental, you know, based on a CT scan with new imaging technology, thanks to the constant support of the industry. This is really the optimal translational research. You can see what kind of pictures we could get. And there were continuous improvement of valve and delivery system over time. You can see here the 3 generations of the Edwards Sapien balloon expandable valve, moving to the Sapien XT valve in 2009, and since 2012, the Sapien 3. Each time, you know, with a decreased sheath size, additional valve size, improved sealing positioning, and improved delivery systems. On the Medtronic core valve, you know, the Medtronic core valve was launched in 2004, and the competition between the Edwards and Medtronic has been extremely positive for the dispatching of the technique in the world. So the Medtronic core valve made exactly the same kind of progress with a reduced sheath size and development of additional size from the core valve to the Evolute and different valves that they are making today. During that time, there was an emergence of a firework of new devices. You can see here more than 30 different devices were investigated. Actually, only 2 newer devices are still in the race in Europe and in the United States: the Accurate Neo from Boston Scientific and the Portico Abbott. These are good valves, but they were unable to prove so far the non-inferiority or superiority in comparison to the historical devices. There is another emergent and very promising device under investigation. I'm a strong believer in the MyValve from Mary in India, who is proposed with a 14 French sheath for all sizes. The valve is pre-mounted over the balloon, which is an advantage in comparison to the Sapien 3 valve, with very large upper cells, very efficient external curve to prevent PVL, and multiple size with half size, and this is an important factor, between 20 and 32 millimeter, the larger size available for optimal annulus coverage. Thanks to these many technologies, the minimalist transfemoral approach became the gold standard for TAVI. And today, the transfemoral approach is used in more than 90% of all cases. And in USA, they were fiercely opposed to TAVI without general anesthesia and transesophageal echo for many, many years, but they are now convinced, and since the last 5 years, 94% of all TAVI procedures are done using the transfemoral approach, with the minimalist approach in 90%. In Los Angeles, for example, the TAVI procedure is done on outpatient basis in 40% of the cases. You know, the patients are discharged on the same day. So we have been pioneering this, what we call the minimalist transfemoral approach, and I'm very proud of that. because today, and especially with Sapien 3, the TAVI is turning into a stent-like procedure. So it means local anesthesia, pure percutaneous approach, no transesophageal echo. Of course, the femoral artery is pre-closed with some pre-closing system. The procedural duration today is between 30 and 40 minutes. Can you imagine that? Valve is shown in 40 minutes, and the patients can be discharged, in our experience, in less than 3 days in 75% of the cases. So this is really something absolutely remarkable. And the lesson 10 that for me was the need to set multiple training programs to teach each updated technique. The reason of techniques is also, the reason of success is also depending on the large body of scientific evidences. I don't give you any. Who have TAVI without entering into a registry. We had some match registry versus surgery in intermediate risk patients, and mainly, and this was absolutely fundamental, 3 evidence-based trial in inoperable high risk, intermediate risk, low risk patients with the Edwards and the Medtronic, and with the Medtronic in Norway. So there are few other medical technology who have been subjected to such great scientific evaluation. And the cherry on the cake is that we had to move a very unusual way, starting with critically ill patients and moving slowly to lower risk patients. In general, in medicine, we do exactly the opposite. So a too large body of evidence. The evidence-based trial, the landmark randomized trials were made in United States. Each of them published immediately in the New England Journal of Medicine. The partner one, we showed that in inoperable patients, the TAVI gives a fantastic reduction of the mortality in comparison to medical treatment. In high-risk patients, then partner 2 in intermediate risk patients in 2016, and partner 3 more recently in low risk patients above the age of 75 years. This is something absolutely fundamental, and it was extremely important for the diffusion of the technology in the world. The same result, the non-inferiority or superiority of TAVI was demonstrated in the 3 trials on main endpoints, all cause of death, stroke, recovery, rehospitalization, and the core valve offered comparable results. So in August 16, 2019, it was the apotheosis of TAVI with the FDA approval for all the patients above the age of 65, whereas in Europe, the technique was approved for low-risk patients above the age of 75 years of age, but between 65 and 75, the patient's opinion is taken into account. So this is what we can observe, this exponential increase in the number of procedures. For example, in 2021, in a single year, 180,000 cases of TAVI were performed in the world, and the predicted growth time within 10 years. And since 2019, the number of TAVI exceeds that of surgery in the United States and now in other countries. So this is the impressive world expansion of TAVI, and there is a lesson from that, again, doing continuous and tiring international on-site proctoring. So now, new label TAVI centers in the continent of Africa. So this slide was made last year, and we see that in Africa, and especially in South Africa and North Africa, many centers have opened. In spite of the low prevalence of degenerative aortic stenosis in Africa and the cost of TAVI, which is a strong limitation, there is a growth of labeled centers year after year, more particularly in South Africa and North Africa. Opening a labeled TAVI center in Africa is something important to meet the demand and allow the treatment of the diseased on site. Teaching optimization program was another lesson. Opening new TAVI centers in Africa, TAVI program optimization where? So there is no specific rule to Africa. You know, your optimal TAVI center, as everywhere else in the world, is a center of expertise with high volume interventions. The centers are supposed to have the cardiac surgery on site, but in Africa, you know, this can be modulated by the specific situation. The equipment have to be of very high quality imaging, cath lab or operative room with C-arm or hybrid rooms. And you need to have an outstanding multidisciplinary partnership. The heart team is something extremely important that you have to observe in Africa as well as everywhere else. TAVI should be undertaken with multidisciplinary heart team, including cardiologists, cardiac surgeons, and other specialists if necessary. Excellent imaging is central. So I don't know exactly what the situation is in Africa, but you can do TAVI today in conventional cath lab with high-grade imaging, spacious environment, and the availability of echo and ECMO, all bailout equipment. Or like operative room, like sterile environment is recommended. Concerning the OR, a theater with C-arm screening is suboptimal. However, some generation C-arm equipment are now approved. Institutional requirement for TAVI in Europe, in USA. Minimal institutional interventional program is normally more than 1,000 cath per year, more than 400 PCI per year, and 30 left-side structural procedure per year, including 60% of balloon aortic valvuloplasty. These are the European recommendations. Minimal institutional surgical program, more than 50 valve replacement per year. It's 200 in Europe, at least 10 high-risk AVR. So these numbers can be also changed, you know, according to the situation in Africa. Training and proctoring programs for those who want to open a new centers is definitely the key. And you have to get to some training programs that are proposed by different companies concerning the staff and team preparation, the equipment. Patient screening is absolutely crucial. The arterial and surgical access, pre-closing, large fist insertion, rapid pacing, pre-implantation valvotomy, manipulation of delivery system, the valve positioning and delivery, evaluation of results, and device retrieval. Tips and tricks at each step of the procedure are very important to observe. And you have to learn the prevention and management of complications. So nothing special with Africa. In Africa, which device should be preferred? Actually, basically, you know, the choice of the device depends on several factors everywhere. You know, the annulus size, the access to the aortic valve, coronary locations and risk of occlusion, the best possible hemodynamics, the risk of PVL, the risk of permanent pacemaker, the risk of prosthesis mismatch, and the reaccess to coronary arteries. Actually, this is based on the quality of CT scan evaluation, and you really need to have an excellent CT lab. Specific training and preference of the team play a role in the selection of the valve, but here, this is the limitation, you know, the unbelievable cost of the prosthesis in Africa, which is clearly higher than everywhere else, and this is something that should be corrected, you know, by the number of centers opening and the competition between companies. In Africa, as in most non-Western countries, the patient age, which was supposed to be more than 65 or 75, might be adapted to the different social demographic features. But whatever the age of the patients must be fully informed, and his opinion must be considered in the final therapeutic decision. As you see here, you know, developing TAVI has been a long, bulky road from the first balloon aortic valvuloplasty in 1985, the first in man in 2002, and the post-commercialization registry, the randomized trial, partner 1, 2, 3, and the expansion to all comers. 37 years since the first balloon aortic valvuloplasty and 20 years since the first in-man case. And the future is bright with an extension of TAVI indications as valve-in-valve and bicuspid valve, which is already accepted. And we have some investigation ongoing, a randomized trial on asymptomatic aortic stenosis, moderate aortic stenosis without failure, and in some other indications. I also am proud to say that this breakthrough technology has opened a new world in cardiology, stimulating the transcatheter treatment of many other valvular and heart disease. The final lesson is that always be ready to celebrate with your team, family, and friends the successive successes of this crazy technology named TAVI. Thank you very much. Thank you. Yes. Thank you so much. Thank you. Thank you.
Thank you, Alain, for this outstanding lecture and a very important review of all the story of TAVI from the inception, and mainly for your recommendations that are very well thought about how to introduce TAVI in Africa and how to expand it. We have something for you. Can we play that video, please?
Bonjour. Il y a des périodes privilégiées dans une vie professionnelle. Bonjour. Il y a des périodes privilégiées dans une vie professionnelle.
Le son, s'il vous plaît.
Celle d'avoir côtoyé le professeur Alain Krivier à l'hôpital Charles-Nicolle, à Rouen, dans le service du professeur Ledac, restera toujours gravé dans ma mémoire. Pourquoi? Parce que le service dans lequel j'ai évolué est tout à fait exceptionnel et parce que le professeur Alain Krivier est tout à fait exceptionnel. En quoi il est exceptionnel? Dans son intelligence, dans sa vision futuriste et créatrice, dans sa ténacité légendaire, dans son dynamisme, dans sa dextérité, ceci, bien entendu, en plus de ses qualités humaines, de modestie, de gentillesse, de grande disponibilité, rendant son approche très facile et sa compagnie très instructive. Merci, professeur Alain Krivier. Vous avez notre éternelle reconnaissance.
This is Gus Bichard from Washington, D.C. I am honored to say a few words about my friend Alain Krivier. This is a picture of him with Hélène Elchaninov and I at his hospital, Hôpital Charles-Nicolle in Rouen, doing one of the first TAVIs ever. I've known Alain since he was a young interventionalist, and he was doing first rotobladers and then was doing the famous metal valvotome for mitral stenosis. And then he went on to develop aortic valvuloplasty and TAVI, as you all well know. And this is a picture of Alain last May in the celebration of the 20 years of TAVI in Rouen. This is Alain receiving his Légion d'honneur in Rouen also a few years ago. And this is Alain about 20 years ago in my house with my children on the piano. And as you see, he's an amazing, talented piano player. Listen to this. Incredible disability. Which most of you probably don't quite know. Alain, congratulations.
My dear Alain, it's a pleasure to have once again the opportunity to tell you of the friendship admiration and respect that you arouse in me and within our entire community. In addition to being a great doctor and a genius inventor, it's your human qualities that make you a man apart. Thank you for all the moments of sharing in Asia, South America, Algeria, in conditions sometimes that any other would have refused. I see you in an even mood with your usual humility and that smirk that never left you, sometimes tired but always available. So let us thank you and honor you again for all you have given us. Keep shining, enjoying yours, and playing piano for the happiness of all of us. Thank you.
Bonjour Alain. I wanted in a few words on this occasion of the 20th anniversary of TAVI celebration to sincerely thank you for what you have done to myself as a wonderful mentor during my training in Rouen, in the United States, and later on. You simply have changed my life and my career in many ways. Your role in the training of many Tunisian international cardiologists, but also cardiologists from North Africa, from Africa in general, has been more than instrumental in shaping international cardiology in Africa. And we would like to thank you for that. You have been supporting the Pci Congress, the Pan-African Course on International Cardiology, as an active co-director for the last 23 years, and we are very proud. Having you on board. Although TAVI is not yet a widespread technique across Africa, but African international cardiologists, they do know everything about TAVI thanks to your presentations and lectures during every and each edition of Pci. So we have been following closely all the steps of TAVI development during the last 20 years. Alain, you are truly an inspiration for all of us, and we still have a lot to learn from you. So congratulations for such a historical achievement, and thank you very much for the opportunity of being one of your many fellows and followers around the world. With my best wishes for an even brighter future. Thank you. So Alain, on behalf of all of us, thank you so much what we have done and to have been doing and what we're going to be doing for us in the future. And I think we have something to give you, simple, symbolic present on behalf of the Moroccan Society of Cardiology and the Pan-African Course on International Cardiology.
En attendant, je vous remercie tous encore pour cet accueil tellement chaleureux et merci pour vos commentaires à tous.
C'est Abdelhamid Mustaghfir, est-ce qu'il est là? Est-ce qu'il est dans la salle? C'est Nabil Barrada. Ah, c'est Abdelhamid. Ah, c'est Abdelhamid.
Ah, c'est magnifique.
Ça, c'est un tableau. C'est un tableau qui est fait par notre ami Dr Nabil Barrada. Il est cardiologue et il est membre du bureau de la Société Marocaine de Cardiologie. Il a fait 6 beaux tableaux. Il va nous expliquer.
Merci, professeur Gamra. Bon, je vais dire un petit mot rapidement. C'est une toile, honnêtement, que j'avais réalisée pendant le confinement, juin-juillet 2020. Et ça parle un peu des étapes de la vie avec l'horloge qui tourne. Mais on va essayer vu l'occasion de l'hommage du professeur Krivier, qui a passé toute sa vie à régler les valves. Et j'ai décidé de l'appeler l'homme qui murmurait aux valves. C'est comme l'horloge, c'est la valve. Donc c'est l'homme qui murmurait aux valves. Voilà.
Merci beaucoup. Merci beaucoup. Merci. Merci. Est-ce qu'il y a-
Professeur Alain Krivier, je vais m'adresser à vous en français parce que c'est
Oui.
un affront de vous parler une autre langue.
Non.
Au nom des cardiologues de la Société Marocaine de Cardiologie, ici présents et ceux qui sont absents, nous vous remercions pour toute votre histoire. Nous vous remercions pour tous les malades que vous avez soignés. Je prie sincèrement le bon Dieu de vous donner la paix intérieure, de vous donner une vie sereine. Et sachez que au Maroc, en Tunisie, en Algérie, vous avez des gens qui vous aiment.
Merci.
Et en Mauritanie aussi, en Mauritanie.
Merci infiniment.
Et on va prendre une photo salamée.
Oui, oui. Qui est-ce que c'est monsieur qui a fait le tableau?
Oui,
Oui.
oui,
Ah,
c'est bien lui.
Merci.
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 That's
Merci. Ah, thank you. Thank you very much. Thank you. Merci pour tout ce que vous avez dit et fait pour. Merci. Mais je suis très heureux de vous connaître. Merci.
De toute façon, tout le monde vous connaît.
Mais-
Nous aurons notre avis, nos 5 premiers cas à la fin du mois.
Oh, formidable. Félicitations. Félicitations. Bravo. Bravo. Merci.
Je peux prendre une photo avec vous.
Oui, je suis bien sûr.
Une photo pour le journal.
On va peut-être.
Une photo.